So this injection is called the buccal. It's actually called the long buccal, but we shorten that to just the buccal. Many of the older dentists and hygienists will only call it the long buccal. So if someone corrects you, that's where that's coming from, but we just shorten it to the buccal. Okay, so we usually give this immediately after the IA to complete the quadrant. What happens is you'll have a long needle to give to the IA nerve block or the IANB. And when you come out of that, you just go right into the buccal. You don't stop and make your needle safe. Usually you could, but usually it is just easier to go ahead and come out and then swing your barrel around to the buccal side and give this buccal block. And then you make your needle safe. So the nerves and other structures that are anesthetized, of course, the long buccal nerve and the buccal gingiva tissue of the mandibular molars. So remember on that picture of that the buccal just gives soft tissue. It does not give pulp or the tooth, but those are anesthetized already by the inferior alveolar or IA nerve block. So then this will come around and give the soft tissue so that you can have complete quadrant anesthesia. So the needle gauge and length is usually 25 gauge. You could use 27. But we use a long, and this is the one injection that normally we want to just come straight out, like I said, and go ahead and give that buccal. And then you would be using a long needle. It doesn't require a long needle. It's just that that's what's already in your syringe. So we don't stop and change needles. We'll just keep using that long syringe to give. But on this particular injection, you're only going in like 2 to 3 millimeters, maybe 4 at the very most, until you contact bone. You do contact a bone on the IA, you contact a bone on the buccal. So, but it's just not very deep on this. So let's say that for some reason you needed just some soft tissue anesthesia on just the buccal side of those last molars, and that you did not need pulp, but the patient was not sensitive to the tooth being scaled, but was very sensitive around the gum tissue. You could just give a buccal block by itself and get that soft tissue, in which case you could go ahead and use a short. You actually have a little more control, I think, over your syringe when you use a short, but this long is just usually given when you're doing a quadrant and you finish it off. You can just use the long needle. This is the target area for the buccal block. You want the needle to be, see where those teeth are, you want it to be between the gingival margin and the occlusal plane. So your needle has to be somewhere in between that spot. And let me see if I can show you on here what I'm saying. It needs to be somewhere between here and here. So this needle could be going, up this way or this way, depending, as long as it's in between the occlusal plane and the gingival margin. So you're going to may have the needle come buccally, and you want your needle to be parallel with the last molar that's in the mouth. These molars on the mandibular side are not always in a straight line, so you want to make your needle, if they're parallel to the very last molar, whichever that may be. It could be the wisdom tooth, it could be the second molar, it could be the first molar. But you would make that, whatever's the last tooth, you make it parallel to that, and then you just go straight back. And you hit very quickly into this bone right here. The buccal nerve comes from the other side of this and will come just straight over like this and kind of comes down here, and the branches kind of come up like this on these nerves. So we're wanting to hit this, the buccal, it may be up here, it may be here, whichever, and come down. But what we're wanting to do is hit really very, very close to this buccal nerve. And when we only give like maybe a stopper full of anesthesia to this. This is a really super easy and really very quick injection to give. The buccal nerve crosses the coronoid notch at the ramus, or of the ramus at the level of the occlusal plane. The picture prior to this didn't look like it was coming across anything. It looked like those buccal nerves were coming straight down. But in fact, it crosses the coronoid notch and comes over onto the facial or buccal side of those last molars. So it divides into lots of branches. One penetrates the buccinator muscle, and that it innervates the buccal mucosa and the gingiva of the lower molars. So we want to direct the needle into the buccal fold. It's always distal and buccal. Those are the two words that we always remember when we're talking about the buccal injection. It's distal, you go behind that last molar, and it's buccal. So it comes out buccally a little bit from those molars, and then you just go straight back. So the bevel is always toward the bone. The depth is anywhere. You could hit it just very quickly, or it could be up to 4 millimeters. So it's somewhere between like 2 and 4 millimeters. Usually it's only 1 or 2. Millimeters are pretty small. So that needle goes in very often. It just connects like boom right away. So you need to advance very slowly, and it says to drop anesthetic as you go. Just want you to know that that is possible, but in reality, if you're only in 1 or 2 millimeters and you are depositing a drop of anesthetic, usually the bevel is not even fully in the tissue yet, and it will be leaking out into the mouth. So I don't usually do that. I just go in and contact the bone. And if you have leakage, it's because the bevel is not completely into that tissue. And then you'd need to come out and maybe move to the right or the left so you can go in just a little bit further. But you deposit 1/8 of a cartridge, which is a stopper full, over 10 seconds. The success rate is super high on this. That nerve lies directly underneath the mucosa. It is not buried in bone. It's just really almost impossible not to make this nerve have complete anesthesia. So you contact the bone, you withdraw just a bit, aspirate twice. If the tissue balloons or the solution runs down the patient's throat, you're going to reaspirate and continue, probably come out a little bit and go in at a bigger depth, and we'll be able to show you that better in person. We don't want the solution running down the back of the patient's throat at all. So then you wait approximately 3 to 5 minutes and for the anesthesia to work. So what kind of complications can we get off of the buccal block? Well, there could be leakage, and it's caused because, as I said a couple times before, the bevel of the needle is only partially in the tissue. So you're going to correct that by a deeper penetration and possible reinsertion. If the tissue is ballooning, it's because the solution is being deposited too rapidly. So you want to slow the injection down. And cheek biting. We want, you can correct that by educating the patient that this buccal soft tissue is going to be numb for several hours, and they need to be very careful that they're not accidentally biting their cheek. So positive aspiration, you could get one off of this for sure, but it's minimal and, I mean, very rare. So hematoma is possible, and if all of a sudden you come out and you have, how that would happen is that maybe you have gone, your needle can like brush by a nerve or go into in and out of a blood vessel or something, and so it's going to make a little hematoma. And it's a lot of times they're about as large as a pencil eraser. And it'll be like this little circle, and it will become very purple. And you always need to be honest with your patient if you cause a hematoma, because it's not your fault. You don't know. We don't have x-ray vision. If this happens, you're going to apply pressure with your thumb and like a piece of gauze in your thumb, and you just hold that over that spot for about 1.5 minutes, maybe 2 minutes. Seems like a long time when you're doing it, but what can happen is that that will help the hematoma not become so large. But you always are honest with them and say the injection caused a little bruise on the inside of your mouth. You could even show them with the mirror. And so when you tell your patient, if you go home and are brushing your teeth, look down your throat and you see this, don't worry about it. It'll go away within a week or so. It's not a big deal. They don't mind most of the time on almost anything as long as you're honest with them. And that's the buccal.